Welcome aboard.
Please welcome to the stage Axios senior healthcare reporter, Tina Reed.
Good morning, everybody. Thank you so much for being here this morning. We're really excited for our event today where we will discuss the prognosis for America's pain management. I'm Tina Reed, senior healthcare reporter at Axios, where I co-write our Vitals newsletter. That covers some of the biggest healthcare stories of the day, and we would love to have you sign up for our newsletter on Axios.com. So we are here this morning to discuss what's next for the state of pain medicine today and some common misperceptions surrounding the state of chronic pain care. We'll cover the patient advocacy perspective, as well as how the NIH is researching pain disorders and how providers today are thinking about the challenges in today's treatment landscape. So our first guest today is Executive Director of Voices for Non-Opioid Choices, Chris Fox. Chris, welcome to Axios. Well, to get started, it seems like a good place to begin the conversation is to talk about what is the status of what we often just refer to as the opioid crisis. What is happening in America today?
Sure. So recently the CDC updated its opioid-related overdose deaths number and noted some improvements. Approximately 75,000 Americans died from an opioid-related drug overdose in the last 12 months, which is an improvement from the peak of about 86,000 Americans dying from an opioid-related overdose death. While that is certainly positive news, I think there are still some caution flags that I would raise. Most notably, when we founded Voices for Non-Opioid Choices about 5 years ago, the overdose death numbers that we would cite from the government were about 130 Americans were dying from an opioid-related drug overdose. Well, if you believe the latest from the CDC, that translates to about 205 Americans dying every day from an opioid-related drug overdose just in the last 12 months. So while there's been progress from the peak, we're seeing that we're still at historic highs, and that progress is not seen across all cohorts. Medicare-age Americans, for example, have seen opioid-related overdose deaths increase by nearly 10% over the last 12 months, and so we know we still have progress. And I think most concerning is that all the analyses that I've read about the state of the opioid overdose epidemic and the improvements that we've seen is that we don't really know what to attribute these improvements to. And so I think from our perspective, from the Voices perspective, we know any progress is good, but we have work to do still.
Let's dig in a little on what you were just saying about some of these cohorts with seniors. Mm-hmm. What's happening there?
You know, we know older Americans interact with the healthcare system more. We understand that, they have accidents more, they're in doctors' offices more, and frankly, they have more surgeries, and so they are exposed to the healthcare system more often than, younger Americans. And so because of that, and because the vast majority of acute pain patients, about 90% of acute pain patients receive opioids to manage their pain. So as a result, they are exposed to a lot of opioids still. And we know that Medicare's share of overall opioid prescribing in this country has increased 75% just since 2011. And so we know that seniors are in and interacting with their healthcare providers, their doctors, their surgeons more often. And so as a result, they're exposed more often to prescription opioids. And so it's not really surprising for us to learn that among the fastest growing cohorts of individuals with problems with opioids, whether that's newly persistent opioid use, opioid dependence, or opioid addiction, is older Americans.
We've talked about this before, about the experience that a patient has when they go into the doctor's office. Can you talk a little bit about what does this look like today? What are patients generally experiencing? Because we've been in this crisis for a while. We've had doctors try to pull back in some instances from prescribing, but what is the typical experience?
Well, again, like I said, 90% of acute pain patients still, despite the state of the opioid crisis, continue to receive opioids to manage pain. We have seen, I would say, very well-intentioned efforts by states and by local governments to try and rein in the number of excess opioid pills in communities. And I'm sympathetic to healthcare providers who, in many cases, are being told to do more with less tools. I liken it to telling a carpenter to build that same house, but I'm going to take away your hammer. And so what we're seeing now is it's not often up to the surgeon or the anesthesiologist exactly what pain management regimen they provide for that patient. All too often, it's up to their health insurance company or it's up to the facility about what they're going to make available to that doctor for that procedure on that day. And so what we try to do at Voices is there are very real federal policy and reimbursement barriers that get in the way to patient and healthcare provider access to non-addictive forms of pain management. What we try to do and what we believe is that we can prevent opioid addiction before it starts for those patients who will go on to develop a newly persistent opioid use pattern after being exposed to opioids for an acute pain incident. And so what we try to do is we try to take down those reimbursement, those federal policy barriers that get in the way, that inhibit patient and provider access to non-addictive forms of pain management.
So before we get into some of that, those legislative fixes, what are some of those non-opioid choices?
I get the question a lot. A lot of people say, I don't know what a non-opioid is. And I push back, I'm like, well, sure you do. Almost everybody, has had oral surgery of some type, right? And they stick that needle in your gums, and everybody knows it feels like it's 12 inches long. And then the oral surgeon will tell you that not to drink anything hot or cold because you could do some damage in there. And you know that if you take a sip of water, you're going to drool it on yourself anyway, right? Almost everybody knows this experience. Well, that's a nerve block. That's a non-opioid that gives very regionally specific pain relief to allow the doctor or the oral surgeon to do what they want. There are other more commonly understood non-opioid forms of pain management. Everybody knows NSAIDs, non-steroidal anti-inflammatory drugs. Acetaminophen, you might know them better by ibuprofen or Tylenol, but those are also non-opioid approaches that, in combination with one another and with some other drugs that can be used during surgery, it's called multimodal pain relief, which combines a number of therapies to give you the same type of pain relief without the need for prescription opioids.
So there was a piece of legislation that did pass called the No Pain Act. Can you talk about what did that do?
Sure. So the No Pain Act stands for Non-Opioids Prevent Addiction in the Nation Act. And what it tried to do was get at the disincentive that healthcare facilities had in making available non-addictive forms of pain management. As you might imagine, there are very real pressures when it comes to our healthcare system and the delivery of our healthcare system. And many of those boil down to cost. And the way that we reimburse in the outpatient surgical setting, for example, put a pressure on the facility in terms of trying to maximize profitability procedures, incentivize them to seek out lowest cost care options. Well, when you're talking about pain relief, the lowest cost care option is all too frequently prescription generic opioid medicines. And so what the No Pain Act attempted to do was to get the economics out of pain management and to provide a separate payment for the facility for the use of non-addictive pain management approaches. And it was passed as part of an omnibus spending agreement that was enacted at the end of 2022, and it will be the law of the land starting January 1st, 2025. And what it does is if you're a Medicare beneficiary who is getting an outpatient surgical procedure, whether that's at a hospital or an ambulatory surgery center, it will give that separate payment to the facility so that they can provide you the non-addictive form of pain management, whether that's a nerve block, a device, whatever that provider or that anesthesiologist or that surgeon might deem appropriate for your procedure, so that they're not defaulting to prescription opioids. And so what it attempted to solve for was that economic disincentive that the facilities had in making available non-addictive forms of pain management. Now, it is foundational, right? We can't do anything without access. And so it's tried to solve for that access problem for Medicare beneficiaries. And so what we are working at Voices on very hard now is to expand this access beyond Medicare beneficiaries to those who are served by, VA health benefits or TRICARE or commercial health plans to make sure that they also follow suit to make sure that their patients can also have similar access in an outpatient surgical setting. It was a great first step. We're excited to see its impact. We know that if it passes prologue, that it will meaningfully increase access and use of non-addictive forms of pain management, and we think prevent addiction and ultimately save lives.
So you're now pushing for legislation called Alternatives to Prevent Addiction in the Nation Act. So what would that do? Is that what would extend?
Yeah, exactly. I think what I say as the executive director of Voices is that my work is not done until every American in every care setting has access to a non-addictive form of pain management. So what we've solved for with the No Pain Act is those patients who are served or who are having an outpatient procedure in whether it's an ASC or a hospital-based setting. But we know that patients interact with their healthcare professionals in other settings, at the pharmacy counter, at the primary care office as well. And so the Alternatives to Prevent Addiction, or the Alternatives to Prevent Addiction in the Nation Act, seeks to make sure that patients, when they are at the pharmacy counter, can also meaningfully access non-addictive forms of pain management and promote true choice in pain management. We know that many patients, when they go to fill their prescription for a generic opioid, pay between $0 and $5 out of pocket for that generic prescription opioid. We don't think that patients should have to make an economic consideration and take extra steps to access a non-addictive form of pain management. So if you ask a patient to choose between a $1 medication or a $100 medication, we know which medication they're going to choose. And we don't think that either patients or family members or loved ones should have to make those choices. And so what the Alternatives to Prevent Addiction in the Nation Act tries to do is tries to make sure that the health insurance companies don't utilize the same tools that they've used in the past, which is to try to steer patients towards cheapest medications, and that we create true choice and a level playing field when it comes to pain management. If you want medicine A, it'll be one cost. If you want medicine B, it'll be the same cost, and make the patients and the providers figure out what makes sense for them. Because again, I get accused all the time. I'm not necessarily anti-opioids. I think that opioids have a patient, a time, and a place, and a procedure. But I am pro-choice in that I think that patients, their healthcare providers, deserve choices in how they manage their pain. And right now, that choice is taken out of their hands, whether it's by health insurance companies who are trying to steer patients towards certain medications, or facilities who are making those decisions for those patients.
How is this being received on the Hill?
I think this is a new policy. It was just introduced in January in the House. It was introduced in February in the Senate. And I think we have great bipartisan support for a new piece of policy. Right now, we have 18 members of the U.S. Senate who have supported this legislation. We have almost 4 members of the House, completely bipartisan, who have supported this legislation. We continue to work with the committees of jurisdiction and leadership to pressure test this and make the case that this is sort of a necessary piece when we talk about solving the overall opioid epidemic. I think, when we look at the federal response to the opioid epidemic, it's been largely downstream. It's how can we help individuals and families in crisis? And we haven't focused enough time or attention on what can we do to prevent addiction in the first place. And what the Alternatives to Pain Act is and what the No Pain Act is they are attempts to prevent addiction, or to work upstream to try to stop people from becoming addicted in the first place, rather than react to individuals and families in crisis.
And then what about, there's also a piece of legislation called the Support Act. What would that do? So
the Support Act is one of those sort of pieces of legislation that, again, has been reauthorized in the past. It's due for reauthorization now. We'll see. But that's one of those pieces of legislation that all worthwhile causes, things like to make sure that the healthcare workforce can deal with increased incidence of OUD. It's created investments and spurred innovation in the development of non-addictive pain markets. And so we're excited about that. It's provided support for first responders and others. It's a meaningful federal investment in the opioid addiction crisis. Again, if I were to be at my most critical, I would say it's incomplete, in that I think we can do more, and we can continue to do more to focus on opportunities to prevent addiction in the first place, rather than reacting to a crisis right now that continues.
Well, we're coming up on time, but I wanted to end on talking about what are the innovations in non-opioid pain relief that you're really excited about right now?
I think we're starting to see a lot of commercial development, and we're starting to see a lot of clinical trial results from new novel therapies that are showing promise. And I think these products can be used in lieu of prescription generic opioids. And so, to the extent that we get those to market, and that patients and physicians and clinicians can experiment with them and use them in combination with one another, I think we're only going to see the treatment of pain improve in our country. I think that we've already seen an evolution in terms of how we treat pain in the United States. If you go abroad, you go to the EU, you'll note that they use far fewer opioids than we do here in the United States. So I think the practice of pain medicine in the United States is improving. I think that the new products that come to market and that are on market right now will only continue to improve, I hope, and lessen our dependence on generic prescription opioids, which has been sort of the default pain management approach, unfortunately, over the last couple of years.
So really reimbursement is the thing here.
I think so. I think, again, I say access is foundational, and without reimbursement, access is really limited. And so, we know that there are other steps. We know we need to do the patient empowerment. We need to empower patients to have those conversations with their doctors before they, undergo a surgical procedure. We need to do the education of the healthcare providers, about the ability to treat pain without prescription opioids. We know we need to do all this, but it doesn't matter to us if they can't access a non-addictive form. So access is foundational, and then we need to build upon that access to make sure that we're doing the education, we're empowering patients to ask questions, and then and only then, I think, will we have an ability to prevent addiction that can start after being exposed to opioids for an acute pain incident.
Well, Chris, thank you so much for your time today.
Thank you.
Introducing our View from the Top moderator, Eugene Scott.
Good morning. Good morning. It's so great to be here with you all, gathered to learn so much about this really important topic. We're so fortunate to work with great partners who make these events happen. And this morning's event is possible in part to our amazing partner, Vertex Pharmaceuticals. Thank you, Vertex Pharmaceuticals, for making it possible that we could even cover pain management today. And so I want to move this conversation forward. And without further ado, I'd like to kick off our View from the Top conversation with our next guest, Paul Negulescu. He's Senior Vice President and Disease Area Executive of Pain at Vertex Pharmaceuticals. Paul? Thank you so much. So good to see you.
Thank you.
Awesome. So can you tell us why is Vertex here today to join this discussion about pain management?
Yes, we're here today to help raise awareness about the importance of new options for pain management.
Okay.
In particular, we want to talk today about acute pain management because acute pain affects so many people, and it's the way that many people get their first exposure to opioids. And just to put a little perspective on that, over the last few years, on average, about 80 million Americans every year are prescribed medications for acute pain. And of those, about 40 million prescriptions include an opioid. So it's an incredible gateway for people to get exposed to opioids. So despite these numbers that are really eye-opening, there's not a lot of information about how patients and prescribers feel about their experience as they move through their acute pain journey. So we wanted to put a spotlight on that, and we conducted a survey of 1,000 patients who had experienced acute pain in the last year, as well as 500 prescribers who had treated pain in the last few months. And that information gave us some insights into how people are actually experiencing that acute pain journey.
So can you tell us some of the key findings? Like, what did you learn from the survey?
I think what we learned from the survey is that despite the fact that people think maybe acute pain doesn't last very long, you kind of get through it very quickly, that actually it has huge impact and disruptive impact on people's lives. 9 out of 10 of the people in the survey indicated that acute pain had a disruptive impact on their life. This included disruption in sleep, included irritability, it included their inability to function, and surprisingly to us, on average, these patients reported missing 19 days of work. Wow. So that's just from an acute pain episode. And then the other thing we learned was that the patients were really anxious about their treatment in acute pain. They were nervous about being prescribed an opioid. They were nervous about the potential for addiction. And they said, 2/3 of them said that if they were an option for another non-opioid, they would take that the next time they had an acute pain episode. And the other thing we learned from the survey is that the prescribers, the physicians, the people that prescribe the medication saw the same things. So they actually confirmed that the patients saw these disruptions and that needed a non-opioid alternative.
So what do you think some of the key challenges in today's treatment landscape are that drive this unmet need?
Well, I think there are several, but the main one is there's a gap in the treatment paradigm that we have today. Chris did a great job of describing the kind of options that patients have, but really, there are two kind of bookends to how a patient experiences acute pain. The first is if you have mild to moderate pain, acetaminophen or ibuprofen, those sort of anti-inflammatory drugs, they can be effective, but not if the pain is very severe. If the pain is very severe, there are very few options other than opioids. So there's a gap in the need, there's a need for safe and effective therapies to treat the more severe forms of pain. That's what's driving a lot of the issue right now. The second is that I think there's a perception that in order for a new medication to come along, it will have to go through the existing medical practices of the ibuprofen, acetaminophen, and opioids. So this is where the discussion of access is so important, because if there are pathways for new medications to be used, that will drive innovation in the field, and we will have more options.
Why is it so important to focus on pain management right now?
Well, it's a problem that's been with us for a while, and so I guess we should have focused on it even earlier, but there's no time like the present. And we're focusing on it today because a lot of progress has been made. Legislation is being passed, there's a lot of awareness in the community, in society, about the need to address this gap and provide better medication for pain. And so we want to just keep that momentum going, and I think there will be innovations in the near term that will give patients more options. So we have to be ready when those come.
What do you think policymakers can do to improve pain management and reduce the reliance on opioids?
Well, I'm not a real expert in policy, and Chris did a really nice job actually of summarizing some of the aspects. But I think there are two fundamental things that should happen around policy that could help. One is, and this isn't just legislation, but also treatment guidelines and just our general approach to pain. One is that we have to recognize that pain is an important part of the patient journey, and it should be treated. So just raising awareness that pain should be managed is one, and the second is to provide policies that allow for access to the medications that people need to treat that pain.
Do you have like a call to action, for those participating in today's session here?
Sure. Well, I think many people are here today because they're interested in this topic. We're interested in the topic of how we treat pain more effectively, how we reduce the burden of opioid use. And I think what I would recommend is that you all take a look at the survey results that we're posting today. There are iPads around the room. You can go to vrtx.com. and just learn about how patients and prescribers are actually feeling about pain, and share that information, use it in your day-to-day work, and try to help us all move forward to address this need that we have.
And is there anything else you'd like to share with us today?
Well, I'm a scientist, so I would just like to share that I'm optimistic that we will be able to bring new options forward to treat patients, and that working together, the entire healthcare community, research and development, patients, advocacy, physicians, prescribers, payers, we can all work together to really solve this problem. I'm optimistic about that.
Well, Paul, I just want to thank you for joining us this morning and sharing so much about what you all are doing. And thanks to Vertex Pharmaceuticals for supporting us here.
Thanks, Eugene.
Awesome. We want you to stay tuned for a few more great conversations, and just stay engaged. Thank you.
Please welcome to the stage Axios senior policy reporter, Caitlin Owens.
Good morning, everyone. Thank you so much for joining us. I'm honored to be joined here by our next guest, who is the director of the National Institute of Health's Office of Pain Policy and Planning. Her work there today is what guides the NIH's Interagency Pain Research Agenda today. Please welcome Dr. Linda Porter. Dr. Porter, thank you so much for joining us today. I want to start our conversation with kind of a, why are we here and why is this even a big focus of NIH's? So what are the biggest unmet needs in pain today?
It's a great question for starters. To start with, I think it would help to understand a little bit how big the problem is. So we have over 50 million people in the United States that are living with chronic pain. And 20 million of those are living with what we call high-impact chronic pain that affects their daily lives. So they might not be able to go to school, they might not be able to go to work. And then if you look at the cost of that to the nation, if we're looking at population level data, we spend about $600 billion a year on healthcare for pain. It's the biggest reason that people go to see their healthcare provider now. And it's also the highest incidence, it's grown higher in incidence than, which is new cases every year, diabetes, high blood pressure. And so it's really affecting millions of people in the US. So for NIH, this is a public health crisis. And many years ago, or several years ago, we were given a huge allocation of dollars from Congress, not just the NIH, but kind of agency-wide. And we have been using those dollars to direct our pain research programs to some of the biggest challenges. Some of those challenges include the complexity of pain. So not all pain conditions are alike. Not all people who have pain are alike. And so one intervention is not going to work for everything. So we're looking at sort of a multitude of different ways to approach pain management in a complex arena and really target that management to personalized care. So we need to understand the person who has pain, their psychosocial, biological makeup, in order to really address them individually and their pain management strategies. A lot of complexities.
Yeah. And well, and building on those complexities, I would imagine that pain management has changed a lot over the past decade or so as we've all become more aware of the risks of opioids. So can you kind of talk about that evolution?
Yeah, so there's actually been a huge change since the opioid crisis really came to the public eye. 1990s, we started to realize that we were overprescribing because the overdose deaths were going through the ceiling. We did recognize at that time that 3 out of 4 people who were in the overdose population had started on prescription opioids. That's changed a lot now. They are not the primary driver for overdoses now. We've had a run with heroin, a run with fentanyl, and now it's sort of multi-drug use. So at that point, there was a really heavy realization we needed better treatments and safer treatments and something besides single drugs. Opioids are incredibly effective pain management tools, but they're not safe. And so when I think the general recognition across the country, not just NIH kicking in to look at different ways to treat pain, but to really start to focus on non-pharmacological strategies and the research that could back that up to bring those strategies into the clinic. So we know that yoga can be helpful. We know that meditation can be helpful. We know that changing your lifestyle and your physical activity can be helpful. We also know that we need safer drugs and other types of interventions. Sometimes an injection can be really effective. And this is more in the chronic pain arena. But the short is that it has to be a multidisciplinary, integrated approach to pain and not a single intervention, especially if it's a medication that's not safe and not necessarily effective for everybody. So we've really changed our research outlook tremendously to put dollars into research on non-pharmacological strategies, on looking at potential new analgesics for development for both acute and chronic pain. And if we think of acute pain treatment as prevention of chronic pain, that's sort of another big descriptor that's come into our radar screen, that we really need to prevent pain from progressing. So acute pain treatment, the approaches are different, but incredibly important.
And before, I want to talk more about that research that you're doing, but before that, just briefly, can you touch on how stigma impacts the treatment of pain?
Yeah. So from a number of different angles, it really can affect a person's pain management. So stigma can be at the individual level, and that could be the person who has pain, who doesn't want to tell people that they're on medications or doesn't want to say it's affecting my life. From the provider, who can often, we have studies out that show that some providers, certainly not all, can deliver care to certain populations, and these are sometimes because of age. So pediatrics, often there's stigma attached there, low socioeconomic status, and people of color may be treated differently. So they may wait longer in an emergency room for care. They may be undertreated, underprescribed for their medications. And it can be on a sort of a higher healthcare system level too. And so what we see there are things, there was a study that came out in communities of color and low socioeconomic status. Pharmacies weren't stocking certain drugs. And so you couldn't get them if you needed them, even if you had a prescription. And so stigma has been huge. And the bias of providers and healthcare systems can result in people not getting adequate care. So it's a big part of what we need to improve. At the NIH, we have invested in at least a dozen trials over the past several years to look at inequities in healthcare, and stigma can drive that, and looking at different culturally appropriate strategies for pain care in areas of cancer pain management, pediatric pain management, and that's in an acute and a chronic pain setting, going into communities and looking at culturally based non-pharmacological approaches and community-based approaches for communities of color and low socioeconomic status. And so we're hoping that we can eventually get those effective interventions to those communities and to those people to make a difference for them.
And let's talk more about research. What is some of the most exciting or most interesting pain-related research coming out of the NIH?
So let me give a little bit of background on that.
Okay.
We were, as the opioid crisis really evolved in the public eye, Congress gave us a huge allocation of money to change our research agenda. And that's called the HEAL Initiative, which stands for Helping End Addiction Long Term. It doesn't have pain in the title, but it's very pain focused as much as it is for overdose and opioid use disorder. And so with those dollars, we were able to build a pain research infrastructure that we had been always hoped for. It was like if we had these dollars, this is what we would do. So we built clinical trial networks to look at more effective strategies in different communities. We built a pipeline for drug and device development that's sort of what a pharmaceutical company would need from start to finish to begin to develop new drugs in a fast, effective, one-spot place. And so we call that our analgesic development program. And that includes anything from new types of models to test for pain, sort of molecular ways to look at the molecular targets that would be promising pain therapeutics, and partnering with companies, pharmaceutical companies that have something cool in the pipeline. So what that's given us through the HEAL Initiative investments, one of the most exciting areas that I see there is understanding how the nervous system transmits signals that keep pain going, even though there is no injury any longer. So we call this like a sensitization of the nervous system. And the treatments that are starting to evolve there have stimulators that can change the circuitry in the spinal cord and in the brain to really begin to change the signals going to or from the brain that make pain prolonged, make it of long duration, and make it go on beyond the healing process. So the neural circuitry behind pain is complex, and there's so many different ways to get at it to begin to sort of decrease the level of pain. The other things I think that have become, that we knew were effective, but are now starting to get more into what we call the implementation phase of research. So once you find out that certain packages of non-pharmacological programs for pain, which can be mindfulness, et cetera, can be packaged together. So there's this integrated approach to pain management that we're really excited about. And a few new drugs are in the pipeline that we've been, kind of working in the background on understanding how they work for years, and now they're starting to come close to release for public use for both acute and chronic pains. Really, really new mechanisms to treat pain, I think is the way I would say it.
Yeah, can you give us a very layman's overview of what those new mechanisms would be?
What the investments would be?
The new mechanisms.
Oh, the new
mechanisms.
Pipeline. Sorry. Yeah. There are a couple of different ways to do it. So one is altering the circuitry of the nervous system. That's really a new approach, and in a couple of instances has been incredibly helpful, but it's not a big market item yet. It's complex, it's hard to put into an individual, there's safety issues, but it's really evolving. We have some molecules that we've been looking at for years and trying to understand that actually are involved in neural transmission, and we call these channels, if you will. So if a nerve impulse sort of jumps and jumps and jumps, and as the electronics change in that system, there are certain channel blockers that have been connected to pain, and some of these are sodium channel blockers or calcium channel blockers, that if we knew how to change how they worked or to stop them at a certain point, we could interrupt the impulses that signal pain. And so there's a fair bit of work there that's been evolving over the years. Vertex is one of the partners that we had worked with early on, and they have got some really exciting things in their pipeline. Natural products can be helpful in some ways too. Obviously, anti-inflammatory markers can help us find better anti-inflammatory drugs. So a lot of different ways. Yeah. And it's really exciting because there's just so many avenues to look at now.
Awesome. So I want to wrap up by talking about barriers. And quick story time here. And by barriers, I mean barriers to non-opioid alternatives. I wrote about this a few weeks ago in my newsletter, The Future of Health. I have had surgery on each foot, and I never took an opioid afterwards for pain management. I had a nerve block. It just was a device that went into my leg. I didn't feel anything. I didn't take a single opioid. To me, having a non-opioid alternative was pretty easy. I just had to ask. I understand that's probably not the case for a lot of people. I would love you to talk about barriers and maybe what was unusual about my experience.
So fortunately, your experience is becoming more of the norm. And so these regional blocks, rather than opioids, can be extremely helpful in preventing pain post-surgery. And so we're looking at a lot of different ways to do that. The anesthetics, different drugs for post-operative pain. And again, I go back to if you can prevent acute pain, if you can treat acute pain, rather, you can prevent chronic pain in a lot of situations. But can everybody get that? No. So in part, it depends on whether you have insurance, whether you have access to good health care. If you live out in a rural area, there might be only one person who can treat you, or it may take you hours to get a surgical center where you could have actually had the procedure. And so whatever the problem was that the procedure was needed for is going to happen and go on and on and on and get worse. And so access to care, reimbursement to care for good pain management, And I think one of the things we've recognized is that our providers don't always get good education in pain unless they're specialists. And so if you go to your primary care provider, chances are that they got very few hours of pain management training throughout their medical curriculum. And so have limited time because of how they are reimbursed, how busy they are in their clinics to actually work through a multidisciplinary and effective pain care program with you. Also, I think one of the big challenges is we don't yet know what works for whom. And so one of our big programs now is what we call biomarkers. And so biomarkers are looking at people's characteristics that make them more resilient to pain or more likely to have acute pain that's severe or go on to chronic pain from acute situation. And those can be biopsychosocial. So, your mental status, your overall health and lifestyle status, but also like what your genetics are, what your physical characteristics of the tissues are. And so the more we know about that, and we've got a really big push now because we always thought biomarkers were impossible for pain. It's too complicated, it's too different, every individual is different. But we're launching in to trying to put that puzzle together. We're characterizing somebody really deeply when they go into a trial. We test different interventions to see what works. So as we move towards personalized pain care, we're going to get much better at it. And the sort of the data management tools that we have now are allowing us to do that. But that's been a big barrier and something that we're working towards, like how do we treat this person in the best way? And it's a challenge.
Well, Dr. Porter, that's a good place to end things as we are out of time. But thank you so much for your time and input today.
Thank you. Yeah.
And for all of you, please stay tuned for our final conversation.
Welcoming back to the stage, Axios senior healthcare reporter Tina Reed.
For our final conversation this morning, we're going to speak with someone who deals with chronic pain patients every day in her workplace. Please help me in welcoming the Assistant Professor of Physical Medicine and Rehabilitation at Johns Hopkins Medicine, Dr. Stephanie Van. Thanks so much for being here today.
Thank you for having me.
I think this is a great place to sort of end today because you actually work with these patients every day who rely on different pain medications. Can you talk a little bit about what you actually see in clinic and why pain is so challenging?
Yeah, I would say pain is a universal disabler. So no matter what someone's been through, surgery, illness, accident, pain can really impact someone's quality of life and their function, and they care about that the most. So when I meet with patients in clinic, especially for the first time, I want to know what their goals are. Like, what do they want to work on? It's not just about treating pain itself. The pain number as the sixth vital sign, I think, was really problematic because the goal shouldn't be to get the pain to zero. It's more about what do you want to do? Do you want to be able to button your shirt up in the morning? Do you want to be able to travel with your family? Like, these are the big goals people care about. And so it's shifting people's perspective of, hey, I want to be here to help guide you through what options you have to work towards these pain management goals.
Now you have a social media channel, This Ability Clinic, and actually in one of your videos, you were talking to providers, and you were talking about the importance of baseline versus normal in the context of pain. Like, what does that mean?
Oh, I love that you asked me about that. There's been great discussion today already about marginalized populations, racial minorities, sexual orientation minorities, rural populations. I think one of the most marginalized groups are people with disabilities and chronic illness. They just got named a marginalized health population by the NIH last year. So we have a lot of catching up to do about looking at how we can improve access for people with lots of different conditions. So when I encourage my colleagues to use the word baseline instead of normal, I'm encouraging them to take a more inclusive approach so that everybody feels like their healthcare providers are partners with them. Normal has a lot of stigma. There's a lot of language in medicine that carries, weight and judgment and bias. And if we can change the words we use, that's sort of a first step into creating a more accessible, inclusive healthcare environment where everyone can feel like they're going to get some help and some treatment and support.
So when somebody comes into your office and they are dealing with pain, I guess what's sort of part of the cadre of options that you currently have available for them?
That's the biggest part of my job. I tell my patients I work for them, and I'm sort of the connoisseur at the winery where I get to lay out the options available to them and that are compatible with their goals, right? So if people want to minimize medication side effects or they want to minimize needles or surgery, like we can kind of tailor the menu options to what their goals are. I start with lifestyle changes, the simple stuff that they can control, like maybe it's sleep regulation, maybe it's mood regulation, or therapies like physical therapy, counseling. And then we get into the medicine stuff, which feels like a big piece of the pie, but really it's one fraction of the menu, if you will. And we're talking a lot today about opioids versus non-opioids, but non-opioids is like a huge category. It depends on what type of pain someone has. Someone might have nerve pain, burning, tingling, numb, or someone might have muscle or joint pain, aching, stiff, and sharp. So really, you're trying to be a detective here as the healthcare provider, helping someone get to the bottom of what's the source of this pain. We're not just trying to cover it up with an opioid, which is, I tell people, it's kind of like a Band-Aid. It shuts off your pain signaling, but it doesn't address the root cause of whatever's ailing someone or making them suffer. So I give them the whole menu of like, okay, you have like mostly nerve pain, some muscle pain, some maybe psychological pain. A lot of people who are suffering, they've been through something that's traumatic physically and mentally. So helping people understand this whole menu of options really goes a long way to partnering with them and showing them that they have many options, many choices that can be compatible with their goals. And then finally, I'm an interventional pain doctor, so I can't be up here without talking about injections, minimally invasive interventions. These are usually in and out same-day procedures. I believe Linda brought up regional blocks. Like that is a really nice minimally invasive, non-pill way to interrupt pain. So there's this whole plethora of options before you think about things like surgery.
You mentioned psychological pain, and I think sometimes when people hear that, they think, oh, you're saying it's in my head. Can you talk a little bit about what do you mean by psychological pain?
Yeah, you just triggered me a little bit. I hate it when people hear that things are just in their head. I really like to reframe that and say things are in your nervous system. Pain is in your nervous system. So suffering, even from past trauma that is healed, whether physically or emotionally, your body just inherently will react in a heightened way because that's how we're built to survive and sort of be prepared for future traumatic scenarios. So when things are in your nervous system, you might be in a heightened state where you might have an exaggerated reaction to a stimulus that's not necessarily harmful, but you can still perceive it as pain. So I always tell people it's okay, it's not in your head, it's in your nervous system. And I classify that as nerve pain or centralized pain. And that's why we have nerve pain medicines, we have centralized pain medicines. Some medicines are also used for depression and anxiety because those kind of follow the same pathways in the nervous system. So yeah, that's why that's, again, a whole category of options on the menu that unfortunately can get kind of dismissed or skirted over.
Actually, you mentioned a pretty silly solution in one of your videos on Disability Clinic. Can you talk about that?
It does sound silly, but I find myself saying it often at work. When someone has a complex neurological issue like complex regional pain syndrome or like pain after stroke, which is an insult to the nervous system, someone can have heightened, exaggerated pain, even with a stimuli like light touch, like clothing can really bother someone, or even weight bearing like walking. You're not damaging anything, but someone can really be limited by the pain that they feel. So I'll tell people, it sounds kind of silly, but I'll tell people to talk to their painful limb. Talk to your ankle, talk to your hand before you expose it to the stimuli. Be like, hey, we're about to do some gentle desensitization. You're gonna be safe, you're gonna be fine. And maybe you desensitize it with some cream, some lotions, you light some candles. You create an environment where the nervous system feels safe and at ease, and then you expose your painful body part to the stimuli. You're helping to reprogram and recalibrate your body's response to a non-harmful stimulus. And this is the conscious control we can have over our nervous systems. We can take back some of that control. Pain is not entirely out of our control.
Wow, that is really fascinating. What are you most excited about when it comes to what's coming down the pipeline in pain management right now?
It's funny, we're talking a lot about innovations and new things and research, which is so important. But I feel like the things that I do every day in clinic with patients, I'm not doing groundbreaking things. If anything, I'm kind of taking a step back. And I think the most important thing I do is help people understand what's happening to their bodies, not just with pain, but with maybe whatever injury or disease that they're experiencing. Because even though, we don't have treatments for everything, we don't have revolutionary drugs to reverse things yet, it gives them, again, that sense of control and that ownership back of, I have some say in my health. And I have a partner now in healthcare who can help me guide myself through these options and make the best decisions for me. That really goes a long way for patients feeling like, okay, I can live with this, I can go through this. And I mean, maybe it sounds groundbreaking. Unfortunately, the system has really swung in a direction where we're not really reimbursing doctors for that time spent. But to me, that's where the value is, and that's where my patients get the most benefit from.
Well, we've been hearing a lot about psychedelics and marijuana, or cannabis, I should say. What are your thoughts on those? Could those be an option in the future in your clinic?
Yeah, when a patient asks me about that, I'm like, I'm open to it, Like, I know there's good research out there, and especially in Maryland, it's available recreationally. Overall, I like that the industry is exploring alternatives, right? We need as many tools in our toolbox as possible. And I like how there's a destigmatization of a lot of these drugs that previously, were very forbidden and stigmatized. I don't prescribe those particular ones in my clinic, but I will offer out-of-the-box solutions. There's a lot of good literature on a couple of compounded medicines, namely like low-dose naltrexone. I don't know if you've ever heard of that, or ketamine even. Again, these might have a little bit of stigma, right? I have to kind of caveat, these are out-of-the-box third lines. They're not yet FDA approved, but they're tools in the toolbox. They're on the menu. Maybe they're towards the bottom of the menu, but if someone's exhausted their first and second line options, it's nice to kind of pull these out of the back pocket and say, hey, there's always something else we can try. Let's start at a low dose. Let's see how you do. And a lot of these medicines help with that reprogramming and recalibrating. And so the psychedelics, or things that alter the nervous system's chemistry of signaling, we're hoping to make the nervous system more plastic, more open to putting down new patterns and undoing old, unhelpful patterns of pain. So overall, I'm supportive, and I'm excited to see more and more scientists looking into these.
And then what about digital tools?
Digital tools like virtual reality?
Yes, exactly.
I find that virtual reality and digital tools are kind of a fancy, modern way to employ older strategies like cognitive behavioral therapy, mindfulness, guided meditation. These are not groundbreaking things. They're things that I think are still underutilized and underfunded, perhaps. Sadly, mental health is not as accessible as it should be. Mm-hmm. And so, a lot of people will face barriers of I can't afford this therapist. They don't take insurance. Or I really like my therapist, but, they're fully booked or something like that. So it's nice that things like virtual reality are becoming more available and creating that access. But I don't think the screen itself, I don't think the technology itself is what's behind the therapeutic nature of it.
Makes sense. Now, do most doctors know about this sort of range of options that you were just talking about?
Absolutely. It's med school 101. I would say it's not a mystery to doctors how to actually treat pain, but I think a lot of doctors, especially non-pain medicine specialists, you're not trained to offer all of these things. It's not the focus of their specialty. Someone is specifically this type of surgeon, or someone specifically is this type of interventionalist. And medicine just gets very siloed. Someone is very specialized into this very cool, specialized thing. But patients don't always need that. The majority of the time, patients need an overview. Patients need sort of an introduction. And that's what helps them make the best decision. I feel like it always comes down to, we work for our patients, we work for people, and that really gets lost. And so I think that's why a lot of doctors fall out of the habit of, practicing these options and literally incorporating this into their practice.
You mentioned earlier that we are experiencing, what you would call a pain crisis at the same time that we're dealing with an opioid crisis. So I guess as we come up on time, could you just sort of talk about how, as a doctor, you think about that tension between thinking about both of those concerns?
Absolutely. I mentioned how pain used to be considered a sixth vital sign, and I think there was a big shift in the movement, not just with the abundance of opioids, but also this focus on, we have to treat the pain. We have to make the pain go away. We have to throw all the things we can at the pain. That's the problem. And I think that really skewed how we treat patients. We're not focusing on these functional goals. We're not focusing on how someone can get back to spending time with their family, traveling, working, the things that people actually care about. We got so fixated on the pain itself that all this energy and time is being put into what medicines, what is safe, as opposed to how can we approach this with a multimodal menu of strategies. I think a pain crisis comes along with a mental health crisis. The world is a really stressful place right now. We're sharing more information than we ever have as a human race. Like, there's news outlets, there's horrors happening all over the world, there's violence, there's tragedy. It's really stressful. And so, of course, that perpetuates the stress response of our nervous systems. It perpetuates our pain, our suffering. And, we've always been programmed to experience this pain, but how can we empower healthcare providers to support people even more during these times? These are not new skills. These are not new problems. They're just even more abundant. And I think the system really needs to undergo a big shift, a big evolution, so that we're putting resources where it really matters.
That makes sense. Well, Dr. Van, thank you so much for your time today. We really appreciate having you here. And to our audience, thank you so much for your interest in these important conversations in this morning's program. We hope that you enjoyed this event, and we hope you don't forget to sign up for my newsletter at Axios.com by heading, and it's called Axios Vitals, and we will see you next time. Thank you.